I'm Tina Chang, and I'm with Centro SOL as well, and I have the pleasure of introducing our next speaker. I think that you would agree with me. We've had a wonderful morning thus far, haven't we? But I'm sure that this speaker will also keep you enthralled. So Josh Sharfstein. There's many things you can read about Josh Sharfstein in the program. There's many things to know about him. So I thought I'd just Google him to find out a little more things about Josh Sharfstein. And as you know, he is active on Twitter, and he's got almost 5,000 followers. So if you want to converse with him more, go on Twitter. My son said, "Don't talk about Twitter, Mom. You're going to get it wrong." But he also has, you've made it when Wikipedia talks about you, so he's got a big bio on Wikipedia as well. But what you do need to know, he's a pediatrician, he's a Maryland native, he's the former secretary of the Maryland Department of Health and Mental Hygiene, he's the former principal deputy commissioner of the U.S. Federal Food and Drug Administration. He's the former health commissioner of Baltimore City as well. So he's got a lot of formers, but now, as you know, he's here with us at Johns Hopkins. He's the Associate Dean for Public Health Practice and Training at the Bloomberg School of Public Health, and it's really great to have him here to talk about what's happening in Maryland and Latinos. So.
Gracias por haberme invitado. Es un placer estar con ustedes. Tina me dijo que tengo que hablar en español, ¿verdad? Okay, tal vez los dos. Thank you for having me. Thanks for Tina. Between college and medical school, I spent a year in Central America and learned Spanish and had a very rewarding time working on public health projects. And my clinical work in pediatrics when I was in Boston was in the the Latino Health Center, Boston Medical Center. So I have a somewhat, still some ability to see patients in Spanish and talk to them. It's extremely important to my training and to my career. So I really appreciate what Centro SOL is doing, what Casa de Maryland is doing, and what all of you are doing for Latino health in the city and the state. So I thought what I would talk about a little bit is just a quick overview of some of the things that we know about Latino health in Maryland and give a sense of how health policy is evolving in Maryland, which is a different story in part from the federal side, and what the opportunities are moving forward to address some of the issues that we heard some of the people in the video talking about with respect to insurance. Let's see. So I also wanted to say that aprendí que muchas personas están haciendo ejercicios. Tal vez debo empezar yo. We'll see. Okay, here we go. So how many of you have seen this report? This is a report the State Health Department put out. It was the first report on Latino health in Maryland, at least in my knowledge, for a while. And it also provided different health resources for people. It's online in English and Spanish. We had it translated. This has some of the basic census information on Latinos in Maryland, about 500,000 across the state of about, according to the census, so this is probably a somewhat significant undercount. The population is certainly growing by the census. It's pretty much doubled every year, every decade, going back to 1990, and growing very quickly, as well as you know, it's growing very quickly in Baltimore. In terms of where the Latino population is coming from, it is pretty diverse. A lot from Central America, and we learned that also during the recent border crossing issue that happened. It's been happening for a while, but became quite public last year. Maryland turned out to be one of the top states for, in fact, the #1 per capita for kids coming from Central America. And Governor O'Malley, who at the time I worked for, I think was probably the most outspoken in saying that we needed to take care of the kids, not turn them around and send them right back into very unsafe situations, and that we had to address the issues going on in their countries. So this is some data from the American Community Survey on the language proficiency, use of English, and place of birth. So of the Hispanics in Maryland, about 40% are not U.S. citizens, and about 40% speak a language other than English, and speak English less than very well. So in terms of the mortality for leading causes of disease, this just shows that there is a lot of consistency with the general causes of death, although I think across everything, heart disease is number one. Among Latinos, the cancer is number one. One of the points that is mentioned here is that the rates are lower than non-Hispanic white rates, although this may not necessarily reflect health because of some of the reporting issues. In terms of insurance, in Maryland, by far, Latinos are are among those who are more likely to say they cannot afford to see a doctor. So almost double the rate of anyone else in the state. And if you look at the population without health insurance, it is, off the charts by comparison. So in Maryland, we certainly see that there's a major access to care issues for Latinos. This is another way of looking at it. Percentage of a population who never visited a doctor for routine checkup is much higher among Latinos than others. Among women getting prenatal care, again, Latinos are the least likely to get prenatal care, or most likely to get late or no prenatal care. Getting into other health issues besides access to care, certain problems are more prevalent among Latinos in Maryland, one of which is obesity. And Latinos get less physical activity than other groups, which is consistent with that. Less likely to get flu and pneumonia immunizations, and are very near the top of for diabetes. And there are an awful lot of, I don't have this metric on here, but awful lot of ER visits for diabetes among Latinos. And so they're probably less likely to have it controlled than others. Among HIV, they're significantly higher than non-Hispanic whites. Tuberculosis is also, while not that common in Maryland, is seen among the Latino population. So those are some of the statistics. We tried to find every statistic that we could to put in that report. So if you haven't seen it, I'd encourage you to take a look and get some information on the epidemiology of health for Latinos in the state. So that's the backdrop. Poor access to health care, certain chronic conditions at higher rates. So what's happening in Maryland in that context? And I think before I go back to Latino health, what I'd like to do is just talk for a few minutes about what's going on in the healthcare system in Maryland, which is unique. Then I'll come back to the implications for the Latino population. So one of the things to know is that there are a lot of preventable deaths in the United States generally. So our healthcare system is, I think, characterized, or our health system is characterized by two things. One is we do a very poor job preventing deaths, much worse, that first graph shows, than other countries. And second, that there are huge disparities in the United States across different populations. Many of you may have seen this map of Baltimore, which shows 20-year discrepancy in life expectancy across the communities of the city. In addition, in the healthcare system, to having a lot of preventable deaths, there are also high costs. So this is sort of like, the couple that goes out to dinner and one complains that the food tastes terrible and the other complains that there's such small portions. So the health outcomes are generally poor in the United States, and the cost is very high. And these three graphs sort of show the employer side, which is the one on the top right with the map, There are, a few graphs in public health that get darker every year, like obesity was getting darker for a long time, or opiate use. And the other one is healthcare costs, which have increasingly strapped employers and families. And so you see more of the cost being shifted to workers. The one up here is the federal budget, that healthcare spending is the single most important driver of the debt. If you look at federal expenditures over time, it's only healthcare that's going up. It's not Social Security, it's not defense, it's not anything else, it's just healthcare. So basically, all the federal budget debates, the shutdown of the budget, everything is about healthcare costs. And the bottom one is the state budget. The red is the increase in healthcare spending in the Maryland state budget compared to everything else, education, transportation, and public safety. So healthcare is too expensive, and we still have a lot of preventable illness. In addition, I just point out that the quality of healthcare and the metrics around healthcare are not great in the United States generally, and not great in Maryland. We have one of the highest rates of readmission in the country, in addition to really not doing all that great on quality scores. So out of all that, this is just for context to understand the situation. If you have poor health, too expensive, and not great quality, the major challenge facing healthcare is how to fix all of those at once. And the insight is that something called the triple aim, which is that if you change the way healthcare is paid for and delivered, then you can achieve better patient experience, lower medical costs, and improved health outcomes. So what does that actually look like? Well, let's say we've got a population of patients that have heart failure, and they're admitted every month. And for heart failure, it's really about fluid in the lungs, and the treatment is often diuretics that gets the fluid gone. So a patient comes into the hospital for a few days, gets diuretics, goes home. And then if they have a salty bag of chips or pizza, depending if they're on the brink, that fluid can go right back up. They come back into the hospital, they get diuretics, they go home. And people can come in and out again and again with heart failure, okay? Now, that's not a great patient experience because they're literally drowning when they come in. They're very short of breath. They're worried they're going to die. And then they have to get admitted to the hospital where they can get infections and other things. It's expensive to admit someone to the hospital every month. And it's poor health outcomes to have people that sick. Now, the concept of the triple aim is if you said, well, look, Josh has been admitted 12 times last year. Every time it cost $5,000. That was $60,000 that was cost. Let's do something different. I'll give you $60,000 next year for Josh. And you have to pay for his hospitalizations, but you can use that money for anything else. That's the concept of the triple aim. Then suddenly it's a little bit different. Wait a minute. Maybe we should send a nutritionist out. If we cut his admissions in half, we'll save $30,000. We'd be able to invest in the community side of keeping Josh healthy. Maybe, there's someone Josh really trusts nearby who can check on him frequently. And so the idea of the triple aim is to change the payment and the delivery of care to improve health, reduce costs, and improve the experience for patients. It's not rationing if the patient can breathe. So something very unique is going on to accomplish this in Maryland, and it relates to hospital payment. And I will do a very quick overview of this, very quick. But Maryland is the only state that sets hospital rates in the country, which basically means that there's an independent commission that gives a rate card to every hospital, and every payer pays off that rate card. So Hopkins gets a rate card, GBMC gets a rate card, Bayview gets a rate card, Mercy gets a rate card. And it doesn't matter if you're Medicare, Medicaid, Blue Cross, Kaiser, they all pay the rates on the rate card, basically. And the uninsured pay the rates on the rate card. It's set. It's the only state like that. In 49 states plus the District of Columbia, Medicare pays the Medicare rate. In Maryland, Medicare pays the Maryland rate. Okay, it's very unique, only state left in the country. And one of the consequences of that, and I'll come back to this later, is that uncompensated care is spread across the system. The cost of that is pooled. It's 7% on every single hospital bill goes to uncompensated care. And essentially what the system does is at the end of the year, hospitals say, I provided $10 million in uncompensated care. And the system says, okay, we're going to build extra $10 million into your rates for next year, so we'll pay for that. So it's the reason there are no public hospitals in Maryland is the rate setting system. It's the only state in the country like that. So there are other things that the system has done. But the problem with the system, there were stresses with the system, and one of the problems was that if you have a great system for hospital finance, it really encourages hospital care relative to other things. And so Maryland is a very big and dominant hospital system, but it doesn't necessarily encourage other kinds of care or what I was talking before, keeping people out of the hospital. And so we reached a situation when I was the Secretary of Health with Dr. Herrera and Charles Milligan at the Health Department. We wrote this op-ed that our goal is not just a healthcare system that covers uncompensated care, but a healthcare system that produces health at a reasonable price. And that's the major challenge of the Triple Aim. And so we changed the rate setting system. Instead of just giving a rate card to each hospital, the new system actually gives a budget to each hospital for Maryland residents, okay? And so the difference there is if it's a rate card, then in order to make money, the hospital has to keep the beds filled. Governor O'Malley used to say that we've been paying hospitals too much like hotels, that they have to keep the beds filled. Is that a great way to think about health? But if you change to a budget for the hospital, then the hospital stands to make money, stands to do better financially if you can avoid preventable admissions. You'll understand why I'm going to this to such detail. It's very important to understand what's going on in Maryland. Because in every other state, essentially, if someone's admitted every single month for heart failure, that's good for the hospital. In Maryland now, as of July 2014, if someone is admitted every single month for heart failure, it's bad for the hospital's budget because they've got their budget. It's just expense coming out of their budget. It's completely different. Today, actually, we have an article published in JAMA Internal Medicine that kind of goes through the system in a little more detail if you're interested in doing it. I also tweeted it. It's true that I have almost 5,000 followers on Twitter, but what Tina didn't say is that they're almost all friends of my mother. So you're free to join me. You can look on the site and just be nice to me on Twitter because they're all watching. So we actually redid the whole payment system to cap the budget for hospital expenditures, to produce global budgets. We said that over 5 years we would get 80% of the revenue out of fee-for-service into global budget arrangements that reward better health rather than just more services. Over 5 years, 80%. And within 6 months, we achieved 95% in the state of Maryland. So as of July, essentially every hospital is thinking about how they can improve the health of their community more. And here's a really important point. It doesn't matter whether the patient is insured or not or what insurance they have. A preventable admission is a preventable admission. If you're a hospital and you have a budget for all the care you're going to deliver to Maryland residents, you can prevent those admissions. Doesn't matter whether you're preventing Medicare, Medicaid, Kaiser, or uninsured admissions. It's a value to you. So the incentives of hospitals are even more aligned than ever with trying to improve the health of Latinos, even those without insurance. And I'll even go a step further, which is in the prior system, where Maryland had a great way of compensating for uncompensated care, there was, hospitals could be sure if they were taking care of patients that they would get paid. Then there, it wasn't the case where they were losing money every time an uninsured patient came in, really. I mean, I'm generalizing somewhat. So Maryland may have had, a system that was really geared to assuring hospital care. Now it is a system that provides incentives for better community care in a way that no other state does. There are 10 hospitals around the state that have been on this alternative payment for about 3 years, mostly in rural areas. And they've seen double the reduction of inpatient admissions, nearly double the reduction in readmissions, and almost 50% fewer avoidable admissions. And I went to visit one in Western Maryland called Western Maryland Regional Medical Center. It's up in Cumberland. And I walked into a relatively brand new hospital, And I walked right back out because I thought I went in the wrong entrance. It was so quiet. It was 60% full, okay? And the CEO came bounding over to me with a big smile on his face, and I thought, boy, if you were the CEO of any other hospital, you'd be spending your time on monster.com looking for a new job, you know? And I was able to get a New York Times reporter to go up there and write about it. If you go to Miami, and I was there not too long ago, and you drive around Miami, you see billboards for hospitals. Like every other billboard is for a hospital. And they usually say, our ER has only a 2-minute wait, our ER is the best ER in town, or my favorite one, which I would have taken a picture of, but I might have crashed the car, was we are the only ER in South Florida that has a sunburn room for rapid triage and treatment. I swear to God that billboard exists, okay? So when I was up in Cumberland, the CEO said to me that they have a campaign within the hospital that's "We hope to never see you again." It's the exact opposite of the Miami hospitals, and that they really, when someone goes to a nursing home, they send a nurse out twice to make sure they're doing well. When they go in the ER, they have a special team that helps with placement. I went up a second time. I brought the governor up there to show him a clinic that they've set up for everyone in the community, insured or not. They don't even take co-payments for the insured. That's how much they don't care, whether you're insured or not, because all they're focused on is their budget. Anyone with asthma, diabetes, and heart failure in the entire county can get a care with a team, with a nurse, a pharmacist, a dietitian, to help them manage their disease, and they've shut down units of the hospital, and they're still making money because they're making money from shutting it down because they have so few people now coming to the hospital, and that's why the hospital is so empty. When I was up there, the CEO had a big smile on his face. He said, we had a team from Johns Hopkins come up because they're going to be switching their financial incentives. They want to see what we've done, and he's been also talking nationally. So this is a good article to read if you are interested. So we did reshape the hospital incentives. It's been called one of the boldest proposal in the last half century to address costs. But my interest is that it is addressing health, not just cost. It's giving a completely different incentive structure. And I'll just say 1 year after we launched, like I said, we have 90% of the revenue in global payment arrangements. There are a lot of different people participating. If you go to the HSCRC, it's called, website, you can see all this online. And there are all types of interesting regional collaborations on preventing illness that are underway. And I'll give you one example. In Hagerstown, Maryland, the hospital took over the school health system. And this school health system was a little bit of a football between the school system and the health department and the county, and the hospital came in and said, we'll run it. And I talked to the CEO and I said, why are you going to run it? And they said, because we think we can break even on the school health system by having nurses, but we'll also give them medical records, and we can make money when kids don't come to the ER for asthma. We're going to really try to make sure people are in good position with asthma, they're in school, and we'll make money because we're on a global budget. So you start to see different things happen. After that, I told that story. I went to this big school health conference on the Eastern Shore, and I said, you guys may start to hear from hospital teams about what is possible to work with you. And 2 people raised their hand and said, hospitals just called me to see what was possible. There are other things that are going on around the state. Just to let you know, this is at a lesser extent or a different extent maybe happening in different places across the country, and the CMS Innovation Center is thinking about different ways of doing payment. Only Maryland has the hospital global budgets because only Maryland has the rate setting system, but this is the trend in healthcare. And I don't think people who are advocating for Latino health should be focused entirely. Health insurance is critically important, but understanding how these different structures are playing out it's also really important to understand that too. I won't get into great depth, but Massachusetts, Oregon, Arkansas, and as politically controversial as the Affordable Care Act is for health insurance, it's not controversial for some of these triple aim initiatives. So you're seeing states, even red states, adopt total different changes in in healthcare payment that may incentivize better community health, which brings in opportunities for people who are uninsured, even if, they're, for whatever reason that makes no sense to me, they're not expanding Medicaid or doing much else. So let me try to bring it together before, and then I'll have time for questions on opportunities in this for Latino health in Maryland. I think that it is absolutely true that the Affordable Care Act creates more opportunities for coverage. It is more opportunities for kids, certainly, and anyone who has legal residence here. But it also provides more opportunities because it strengthens safety net institutions. So, for example, Healthcare for the Homeless gets a set grant from HRSA as a community health center. And they have to spend that for the uninsured. Well, their rate of uninsured went from 80% to 20% when the Medicaid expansion happened. So they still get the same grant. So a lot of the health centers are in much stronger financial shape because of the Affordable Care Act. And then really they can use that money, more for people who don't have insurance because they can't get it. So I think that there are direct and indirect opportunities for better coverage in the Affordable Care Act. There are still significant gaps in access, and there are some areas where I think there's been, I think that partly by providing access to insurance for people who are have legal residence, it's created the need for programs that are more specifically designed for the uninsured or people who don't have legal residence because, programs may be ended because of the Affordable Care Act. And I think that is something that needs to be watched. I also think that there's this focus on the triple aim is creating incentives for prevention for all patients. So for example, you're working in a community that has high diabetes, high preventable admissions for diabetes. It's not just the fact that a patient may be uninsured and doesn't want a bill that matters. The hospital would rather the patient be healthy now and out of the hospital. So it's an opportunity to engage in a conversation with the hospitals in Maryland, which have global budgets, about are there ways to partner to keep patients out. I think that you're going to see, for example, Hopkins very interested in the work of Central SOL, even more interested, in potentially opportunities to grow the investment that Hopkins has made because of the ability to reduce preventable admissions, which now provides an economic benefit for the hospital. I also think that that creates opportunities across public health and healthcare, because if there are things that are putting people in the hospital that actually have a public health solution, then people can work together to try to address those too. And those could be occupational risk factors or other things. I think if nothing else, the healthcare system has a new vested interest in Maryland in seeing fewer people come to the hospital, unlike every other place in the country and most places in the world. So it's worth thinking about that differently. And usually when I was a health secretary, I would say, don't assume that when someone said no about something 5 years ago, they're going to say no now, because the switch has been flipped on the financial incentives here. There is a need for data, better data than we have here, and there's a big effort in the state, and I could have gotten into that more, to try to get better healthcare data for Latinos. And so we're not showing data from 2006 to 2010 and 2013, and that work is going on across the state. There's a need for programs, and there's a really important need for partnerships that cross between community organizations, organizations like Centro SOL and even the hospitals. So let me thank the health department for helping me put this together, and I'm happy to answer questions. Thank you.
What is the helped the undocumented community?
Sure. So MHIP MHIP I think is ended. I don't think it's available in Maryland now. But let me tell you a little bit about that and the situation. The MHIP was a program for people who are chronically ill. So you had to be denied insurance in the private sector. And there were two parts of MHIP. One was just getting coverage, which was supposed to be, you can't get it in the private sector, but we'll sell it to you at a private sector rate. So if it was $200 a month to get insurance in the private sector, but when you applied, they said, sorry, you have a pre-existing condition, you can get it for $200 in the private sector. And I'm sorry, you can get it for $200 from MHIP. There was also a special program that provided a little subsidy, not a huge subsidy, not nearly as high as the Affordable Care Act, for example, but that got you to about maybe $150 a month or something. There, it was a sliding scale, but it was not that generous. So under the Affordable Care Act, there's been, I would say, maybe some increase in rates as the risk pool expanded, because MHIP, under the Affordable Care Act, you cannot deny for pre-existing conditions. And the individual market has both the exchange and the non-exchange. To get health care through the exchange, you have to be a legal resident. But off the exchange, you do not have to be. So basically, let's say, this is just pulling numbers from the sky, $200 insurance someone could get if they, through MHIP before, maybe $150 with the premium. Say now it's $225 or $250. But they have a right to it in the open market, not through the exchange. So I would say that this would be an example. We shut down MHIP because it was part of the deal really with the Affordable Care Act, that because it existed really for people who couldn't get coverage on the open market. But now that everyone could get coverage on the open market, there wasn't really the whole justification as originally intended for MHIP as a high-risk pool had gone away. The good news is people aren't going to be, whether you're here legally or not, you're not denied in the private insurance market. But the bad news is there was a little bit of a subsidy you might have qualified for, under certain circumstances. So more people probably are able to get coverage on the open market, but it may be a little bit more expensive. Not grossly more expensive, but that can count for people. When I was health secretary, I got called about a few people who had been on MHIP and who were losing MHIP and were worried. And I engaged with that, and I know at least some of those people were able to successfully transition to private plans. But it was definitely a big switch. I hope that starts to answer your question.
Thank you. That was a great answer.
Okay.
Good morning.
Yeah.
I enjoyed your presentation today, and you spoke on increasing access and coverage to a growing population. But one part of the equation that has yet been discussed is the extent to which we increase and train and recruit Latino physicians, healthcare workers, those who are bilingual, those who are culturally competent. So my question to you is, to what extent is the Affordable Care Act really revving up their energies to tap into that endeavor?
Sure, a very important question. So my understanding, there was a whole workforce effort of the Affordable Care Act. Let's get a little bit into the way that the Affordable Care Act was done. Congress has been Republican for a while now, right? But the Affordable Care Act is still going on. The Congress has to pass the budget. Why is the Affordable Care Act still going on? You know why? The answer to that is that there are certain provisions of the Affordable Care Act that were written in as mandatory appropriations, that were written in the Congress. It's not subject to the annual appropriation cycle. So that's why there are subsidies and grants and all these things. Otherwise, Republican Congress would never have voted for them. However, not all the Affordable Care Act was written that way as mandatory appropriations, and the part for workforce was written as annual appropriations, and to my understanding has never been funded. So there's a congressional issue, there's actually a whole section of the Affordable Care Act, I think, that relates to workforce, if I'm wrong about this, someone can jump up and correct me, but I certainly knew as of like a year or so ago, that part of it hadn't really been moving. With respect to Maryland, there is an effort that is being led by Johns Hopkins School of Medicine and by the University of Maryland School of Medicine to think about the implications of the unique Maryland model for medical education. And since you're at the medical school, I would certainly encourage you to connect up with that. I think that they're thinking about how to teach physicians differently, but I think it is totally appropriate to think about workforce as part of that. It is absolutely the case. It's a combination of things. There's a huge gap in general in primary care in a lot of places, including Maryland, and having bilingual people matters a great deal. I remember when I applied for pediatrics residency, I thought, there are two skills that really, really, really matter that aren't anywhere in the formal review process. One of them was being able to speak Spanish, and obviously people who could speak natively and fluently had that skill really high, right? And I maybe a little bit less than others, because it just helps so much as a resident. But the second one was actually having breastfed a baby. That is just like huge value in pediatric training. But I think that there are ways that the healthcare system should recognize the important value that being able to communicate people really does. I remember my very first rounds in pediatrics, and I stayed behind as a medical student at Children's Hospital. They did these big group rounds, very formal, and it was clear to me that the mom had no idea what was being told to her, so I stayed behind. I was the third-year medical student. I was the lowest of the low on the team. And I kind of like hung behind and gave a little explanation, like, está mejorando, tal vez un día más en el hospital, And then we finished the rounds at the end of the floor, and the whole team walked out, and there were 6 moms waiting for me. And the attending and the residents were like, what's going on? And they were like, no, we want that guy. And the one mom was saying, like, he's the one who's going to actually explain what's going on with our patient. So I think it matters a great deal to have doctors who can converse. Yeah.
I'm just wondering about some advice about advocating for Latino adult health to hospitals, because I feel like they don't currently feel at risk for this population because it's invisible to them. And it's hard to demonstrate a cost savings because there is a very low rate of emergency room hospitalization. So we don't have that carrot. You can get ahead on your global budget because they won't come to the ED. Well, they don't come to the ED anyway. So, so I just, with time, the population will age, and just by virtue of aging, there will be some health consequences. And as we learned earlier, by virtue of acculturation, an erosion of health. But it seems so tragic to wait for that.
Well, I think that there's, I didn't put up, I don't think I had the slide, but I think that the new financial incentives are about 6 months old in Baltimore City. It's going to be a continual conversation. I think it's going to be easier for people to really go for things that have an immediate impact. Childhood asthma may be one, or, you'd look at what I think OB and safe births, and that may be another area that is pretty immediate. But I think that partly you should try to figure out, I think the more you can understand about who is coming to the hospital and for what, I think it'll be helpful. I mean, the flip side is it's not that expensive to provide care to a largely healthy population. So you're not asking for that much, So, and I'm happy to, come over and strategize a little bit more about ways to do that. But I do think that the conversation is changing, and it may well change even more depending on immigration reform. So, I think that we have an opportunity. I guess I would say that the future in Maryland, at least, has some bright spots to it. If as these things are coming out, and it's important to be aware of that as you're trying to fight a really difficult battle, but important. Yeah.
Hi. So I was curious about this hospital in Cumberland. Their population is, how much of it is Latino, and the measures they took to reduce admissions, how translatable is that here at a big city hospital like Hopkins with the Latino community? Sure.
Very low Latino population in Western Maryland, very low. They did a number of things, like I was telling you about the, transitions of care were very important to them, but they did look at chronic illness, and the idea that anyone with those conditions can be seen anytime. You just walk in and there's like a kiosk and it says asthma, diabetes, heart failure. And Hopkins is in fact going out there to learn what it could be, but it will look different in Baltimore. I mean, I think healthcare is changing pretty rapidly and the incentives are changing pretty rapidly. And I think there's a chance to think about and to work on what would it be that could reduce, could improve health first and reduce hospitalizations, and think about different ways to partner around that. The other thing that I should mention that is available in Maryland, as we're talking about Maryland, that may be of interest to you all. How many of you all are familiar with CRISP, the Health Information Exchange? So every hospital and ER provides data to a health information exchange. That's very unique to Maryland also. And Maryland does something really interesting with that, which is they can do a notification. So if I take a set of patients that I'm responsible for and I upload them to CRISP, it will know when one of those patients is in the ER, and instantaneously, while they're still registering, essentially send a note, a secure email to me and say, your patient, Tina Chang is in the hospital, if Tina were less than 18 years old. So there are ways to use that to track, but also to provide other types of services. There's a conversation, I think, to be had with the Health Information Exchange with the consent of people, with the consent of the people themselves. Those notifications could go to case managers and others. So, rather than, if you're responsible for a population, you should be thinking about whether you can get those notifications so that you can be helpful to people in the moment of need. And then second of all, you could have quite an understanding of their use of hospital services, and they're increasingly creating dashboards and other tools for practices about the hospital utilization of their patients. So there's some really interesting data tools that could be put to this in the state. Yes?
So I just wanted to mention that from the OB perspective, our understanding is that we actually have no additional incentive to take care of uninsured patients because the hospital is given the universal budget. And so therefore, so I'm at Bayview, even though we're located in the Highlandtown area, that economically it's not to our advantage to increase our services to primarily Latino patients. The hospital has decided that it wants to take care of those patients, but if you could comment on the consequences of the new payment structure in Maryland on that.
Sure. So if you pay for every service, then you get a lot of services. If you pay a fixed amount, then you have the potential that people can try to get the patients to go somewhere else. Probably the single most important thing for the success of the Maryland initiative is for the ability of the payment system to punish, frankly, hospitals that are trying to inappropriately reduce volume. And there are different techniques that the system has to do that. Looking at changes to services is definitely one of those. There are some interesting techniques that can be used. For example, if Hospital A is getting 70% of deliveries, but all of a sudden is only getting 50% of deliveries, that's a flag. And the hospital's budget should be cut, based on the changing market share that it has. And it's not that hard to set a budget in the first year if it's pretty much based on the previous year. The key is how you adjust the budget and what you do. The person who runs the rate setting commission is a longtime hospital consultant who knows all the tricks of the trade for hospitals. And she's been really blunt to the hospitals about, we want you to succeed for the right reasons, not the wrong ones. It certainly does help that we have hospitals that are nonprofit with very strong community commitments. I think that is a good starting place, but it doesn't guarantee the outcome. And I think that there's plenty of ways for the healthcare system to reward and make sure that people are not getting penalized for doing the right thing for community health, and there are also plenty of ways for the system to penalize people who are going the wrong direction. So I think as advocates, it's important for you to keep an eye on that kind of thing, and you should keep an eye on the rate setting system and understand the tremendous power they have over the budgets of hospitals in Maryland. And if you see concerns, you should definitely raise them. I think that this is very much in the mind of the people who are designing and implementing the system, and there's potentially huge disincentives for hospitals to do less inappropriately, but it'll play out in front of us. Yeah.
This is more of a comment than a question, but I'm Stephanie Clapper from the Maryland Healthcare for All Coalition. And if this discussion interests you, we are actually hosting forums about the changes in the ways that hospitals are being paid. One's on June 2nd in Towson, and one is on July 9th in West Baltimore. And if you are interested, please come up and talk to me. I have invitations. If you give me your card, I'll send you the invitation. And we at Healthcare for All are specifically looking at ways for hospitals and faith communities to start working together in order to keep people healthy because of the new financial incentives. And we would love for all of you to be a part of that. We want as many voices at the table as possible. So I'm Stephanie. Come find me later.
We have time for one last question.
I'm curious about length of stay and how that relates to hospitalizations. And I'm in the mental health field, sometimes I feel like we see sometimes patients who might benefit from spending a little bit of, like, having spent a few extra days in the hospital to stabilize in the long term may actually help the patient. So it seems sort of counter to what you're saying, but oftentimes we see people, it seems like they're discharged maybe prematurely and that there's this kind of pressure to decrease length of stay.
So within a particular length of stay, there's for a long time, within a particular admission, there's for a long time been an incentive to reduce utilization because of the DRG system that kind of pays a flat amount for a particular admission. I should be more of an expert in how that's affected mental health. It's in different, mental health is not quite the same as other services for the Maryland waiver. So it's a little bit different, but the greater incentive in Maryland is to reduce preventable admissions altogether rather than to shorten the length of the admission for a few reasons. And there's been an incentive for a long time to shorten the length of an admission. I think that there's tremendous opportunity for behavioral health in the new system in Maryland, and I'll give you just a couple real quick examples, which is that, patients with serious mental health and behavioral health disorders are so much sicker on a medical basis. They are admitted so many more times for their medical illnesses than they are for their psychiatric illnesses, typically. A lot of them may have diabetes, they may have heart disease, they may have asthma. They're admitted again, or trauma again and again and again and again. And one of the first things that those community hospitals did when they went to the global budgets 3 years ago is they showed up in my office and they said, we're hospital CEOs and we're noticing half of our repeat ER patients have serious mental illness. What do we do for them? And I kind of thought it was like candid camera, like when the hospital executives come in and ask about, but sure enough, they were totally interested. They were Frederick set up a ER diversion program with the Mental Health Association, Frederick Memorial Hospital, because of its global budget. And there have been a lot of efforts to try to address that. There's a huge opportunity now because there's just that people are looking at their data and saying, where can we prevent admissions? And so many of the people who come back again and again have these behavioral health problems. And we've set up a different way of paying for behavioral health, which we hope will be helpful to that in a lot of ways. But I think it's also a new, different conversation there too, and it's primarily because of the medical costs so suddenly people are really excited to work on this. And again, I hope it should be for being done the right way. I think that whether someone's ready to leave the hospital at this point in time has some financial impact, but also has a lot to do with different ways that payers have behaved. I mean, that issue has been around for quite a while, as well as the way clinical standards are enforced. But I think that there are new opportunities for better community services for people with serious behavioral health issues. All right. Muy bien. Uno más? Yeah? Okay.